podcast. I'm Dr. Naomi Lawrence-Reid, your host, a pediatrician and creator of the Doctoring Differently digital course that teaches physicians of all specialties how to find and explore flexible, lucrative careers beyond full-time clinical medicine. For more information, visit doctoringdifferently.com. Today, I'm joined by Dr. Bradley Block, an otolaryngologist and host of the Physician's Guide to Doctoring podcast, a scintillating and engaging podcast where he interviews physicians and non-physician experts to help teach us what we should have been learning while we were busy memorizing the Krebs cycle. I'm so excited about this guest and all of the guests on the podcast. You won't want to miss any of it. Subscribe to the podcast on Spotify, Apple Podcasts, or wherever you get your podcasts. And subscribe to the Doctoring Differently YouTube channel to watch all of the episodes on YouTube. And now for my conversation with Dr. Bradley Block. All right, well, welcome, Dr. Block. It's exciting to have you on the podcast today. Thanks for coming.
I'm super excited to be here. This is awesome. And Brad, please.
Brad, okay. Well, thank you, Brad. This is full circle for me for our listeners. When I was just beginning the Doctoring Differently platform in 2021, Brad invited me to be a guest on his podcast, and that was the first time I had ever been given a microphone and a platform to at least talk about Doctoring Differently, my course, my mission, what I was imagining that life could be for doctors and for myself. So I am really happy to have you on the podcast now that I'm here and established 3 or so years later. So thank you for the opportunity back in 2021.
Oh, well, I love what you're doing. I think it's so important for physicians. And, what I preach is teaching everything, as I say, everything that we should have been learning while we were memorizing Krebs cycle, all that like useless stuff we never use. And all you are preaching is practical information that we can use to help us be better. So I love what you're doing here, and I'm glad to be a part of it.
Thank you. I think there is real overlap here between what you do and what I do, and glad to have this conversation. So with all my physician guests, I like to start in med school. You're an otolaryngologist. Why ENT?
It was kind of a circuitous path. I started off, before I was in med school, I was actually a personal trainer. And so I thought I was going into PM&R. Right. That's what I thought my passion was. Turns out I was more interested in like interventions than medical management. And so then I explored all sorts of different paths, like maybe interventional radiology or, and then I did I thought I was going to do pediatric cardiology, and oddly, eyeballs of all things grossed me out. So I was like, I'm going to see kids with eye injuries. I need to get over that. So I'm going to do an ophthalmology rotation. I did not get my ophthalmology rotation. I get my ENT rotation, which was my second choice. Okay. And I was like, holy cow. Like, this is what I want to do. This is super cool. Yeah. We do. And like, there's a bunch of different aspects to ENT. It's like we have these 3 connected organs that is what makes up our field. But like, a lot of times they have nothing to do with each other. Like we're like, if you're an ear surgeon, you're drilling out bone and looking out for like the semicircular canals and the facial nerve. And if you're a head and neck surgeon, you're like in the neck and mouth doing, giant resections and putting them back together with free flaps. If you're, I do a lot of, I'm a general ENT. I see a lot of kids. And so it's like tubes, tonsils, and adenoids. I do a lot of what I do is like endoscopic or transoral. Okay. Like I'm not doing those big open surgeries anymore, but there's like such a huge variety of what we do. It's amazing that like we managed to train in all of it in a matter of 5 years.
I see. You may have inspired a few medical students listening to consider ENT, because I've never heard it broken down like that ever. So
we're scared away from it because it could be that. It could be that too.
Sure. Okay. So that was all that circuitous path you took. Seems like it was all still in medical school, which is what our 3rd and 4th years are for, to make that journey. Yep. How was residency?
Brutal. I mean, it really was. first year we were still owned by the general surgeons mostly. So I did like a transplant month. I did a urology month, which is super nice.
Okay.
But like a lot of the stuff wasn't really preparing. Now we have the residency programs have more ownership of the intern year to make sure that you're doing stuff that really prepares you to be a otolaryngologist.
So ENT has taken over some of your intern year now so that you're not doing all the gen surg stuff. It used to be we were
just gen surge, and now and actually even before my time it was 2 years of gen surge and then 3 years of ENT. Now it's 1 year of gen surge, but it's really not. It's it's a lot of different stuff that's the program directors have more control over from the ENT department. And then second year is like kind of like an intern year all over again, but you're like the because it's your first full year on ENT, and then that was brutal. It was just residency was rough. Me and my co-residents, it was a three-person program. We really leaned on each other a ton. They became my sisters. Unfortunately, we've somewhat fallen out of touch. It's like I'm 12 years out of residency.
Hopefully they're listening. And what are their names? So if they're listening, first names. What are their first names? And maybe you all can have
Melissa and Roberta. Melissa and Roberta.
Melissa and Roberta.
I love them. I love them, and I miss them. They are two amazing humans. And we really, we got really close. That's what happens. You're a small program. It's rough.
Yeah.
We
Trauma
got really
bonding.
tight.
It's a thing.
Yeah, exactly. And then I finished and I joined the practice, the same practice that I've been with for the last 12 and a half years.
Okay. All right. So how'd you find yourself in your first job, and how's it been going as an attending?
So I interviewed, it's funny, I'm from Long Island. I never thought I'd be back on Long Island practicing like 5 minutes from the giant mall in the middle of Long Island. So here I am. I also interviewed in Miami. I was like, you know what, I'll try something different. But it just wasn't for me. Miami just wasn't for me. So I ended up practicing on Long Island. And the way that I found the job was my practice at the time had like 110 or 115 physicians. All ENTs are allergists. Huge practice, well-oiled machine. And I was interviewing with other practices which were like 3 or 4 other people, or a multi-specialty group, or a hospital system. And it just seemed to me like that this dual specialty group was the way to go. Like they really have it together, and they're owned and run by the physicians. And to me, it was a no-brainer. And I've been drinking the Kool-Aid ever since. And now we've grown to 250 physicians. I'm not in the leadership. It's like we have a physician board that's elected by the partners. But the thing that makes us different is we have a clear path to full equity partnership.
Wow.
So you join us and you go through, what's expected of you. You will have just as much equity as me, who's been with the practice for 13 years. So like there's no other practice like that. Like every other practice is like, yeah, you'll become a partner. Well, not really a partner. Like I'll call you partner, but it's still 90% mine, 5% his, and 5% hers. Like it's not really a partner. This is full equity partnership, and there's nothing like it. So that's why I'm drinking the Kool-Aid.
Yeah, I don't hear about that kind of practice really existing anymore, or really existing ever. So that's wonderful. Okay, so sounds like you are someone who oftentimes I'm talking to a physician who was unhappy in their first couple of attending jobs, decided to make a career shift transition, doing something different. I think that you are probably one of my few physician guests who is still full-time clinical, as far as I know. But when and why did you start the Physician's Guide to Doctoring podcast?
Well, so I saw that my partners were able to see patients much more efficiently than me, right? Like I was always slow. I was always like in office hours, I was slow. Actually, in the operating room, I was slow. I was not the fastest surgeon, not the fastest seeing patients. It just like, took my time. But now there are people in the waiting room. So if I'm slow, it's not like I'm a resident and then the attending is going to help me catch up at the end, or the other, whatever. It's just on me. So the waiting room's filling up with people, and they're getting angry and they're getting upset. And I'm like, well, what can I do differently? Now, I also saw my wife, who's not a physician, but she is very socially adept. Like she'll go to a cocktail party and everyone will leave thinking that she is their new best friend just because she's amazing at that. And I'm the opposite. So I don't have those social skills. Certainly my patients would attest to otherwise because one, I work on it. And two, the exam room is still that's our home. That's where we feel most comfortable. Like you're in my house, right? But how could I do it better? How could I do it more efficiently? There must be people out there who can teach me. And so that's what inspired me to start the podcast. How do I get these people in front of me so I can learn how to interact with my patients more efficiently without losing their, or rather having them leave feeling fulfilled, feeling like it was a productive visit, feeling like they were heard, and yet not having that visit take forever. There has to be a way to do that. And throughout medical school, all I heard was, you need to listen to your patients. You need to listen. You need to be a better listener. Doctors interrupt. You don't interrupt. You got to listen. And it's like, yes, but how do we do that while respecting the time of the people in the waiting room and respecting the time that are having trouble getting access to us? So if you made every appointment an hour, they can talk all they want. But now, access to you is really limited. So how do you respect all three of those people at the same time? The one in front of you, the one in the waiting room, and the one who's at home trying to get an appointment. You have to be able to do this efficiently. And so a lot of what I do on the podcast is having people in front of me who aren't necessarily in medicine, but can help us with those communications. Now, when I started the show, it wasn't like I could just, without a show, call up some strangers and be like, I'd like to talk to you. So I started with my circle.
Okay.
We went to medical school, so we know experts,
That's true.
We're surrounded. Our social circle is surrounded by experts. Like we might not have been the one that wrote Harrison's, right? But we're still experts in our field. So I started off just calling the people in my immediate circle who were experts and like, hey, I'd love to interview about a topic. And so one of my first episodes was about advocacy. So and one of them was about health policy. One of them was just a GI doctor telling us everything that we should know about gastroenterology, even if you're like, a neuroradiologist,
Sure.
So it was, it quickly escalated expanded rather from just being about the doctor-patient interaction to being about really, and that's where the tagline comes from, everything we should have been learning while we were memorizing Krebs cycle. So it really exploded from there. But my North Star has always been optimizing that interaction.
That's fantastic. What you touched on, I think, is something that I often allude to, is that we as physicians are kind of, we've been built to be very individual. Networking is not a part of our education, not like business school or law school necessarily. So we're just so isolated, right? And we're so competitive. And there's, as soon as we get to the end of medical school, it's surgeons over here, peds over there, radiology over there, anesthesia over there. And we become so tribal. We get into our residencies and beyond consults, we're not really having those conversations with each other. We're probably growing some grudges against for other specialties. They have it better. They have it easier. They're not nice. They never admit to their service, and we get those, and we never really have those a real conversation. I'm hearing hospitals aren't even building hospitals. They're not including physician lounges really anymore. So physicians really don't have any place. Yes, I've talked to some physician architects. Some hospital architects who have told me that hospitals are not wanting to put in physician lounges. We can imagine
you don't want a place
that
where you can put your feet up.
That's right. That's right. If you're putting your feet up, you're not generating profits for the hospitals. And every space, right? Every space in a hospital should be at some point some sort of conduit for patient flow.
Billable.
But to the point, exactly. You said, your mission with the podcast is like having those conversations that we are not having across specialty. I think we have all so much to learn from each other. And so you and I think, are hoping to break down some of the tribalism we have across specialties as well. So what have you learned from interviewing so many physicians? What has surprised you, if anything has surprised you, from talking to so many physicians in your podcast?
Surprised me. That's a tough question.
Okay.
So actually I had a conversation recently with a health economist for an interview for the show. And the intention of it was what is, like, it was about unions. The original intention was he had written a bunch of academic articles about physician unions. So I was like, this is the guy I'll have on the show about unions. It ended up that it wasn't really about unions. It was about what's going to save healthcare. And his answer was physicians. I was like, yeah, but we're not in the room where it happens. We're not in the room where it happens, right? Like, it's all these executives and, you know, we're just basically revenue generators at this point. Right. We've been commodified. We're commodities, right? That to be bought and sold at this point, right? That's what private equity has demonstrated. And he said, no. The way that physicians can save healthcare is one, physician entrepreneurs like you, right? Physician coming up with great ideas. You're on the ground with the patients. You see what the problems are, and you can pull out of one of these systems and then create your own venture that can then help patients without this large healthcare system. So that's one way. Another is, like my practice, physician-owned and run practices, so that aren't owned by someone else. They're owned by the people that are seeing and run by the ones that are seeing the patients. And the last one was physician unions. It's a way to take back control and leverage what we do against and push back against those that have commoditized us. And so those were the three things that surprised me. I was like, it didn't occur to me that we had as much power as we do, although it really puts a lot of expectations on us. Like, we got to go save healthcare. Like, I'm sorry, I'm busy seeing patients.
I know.
I can't save healthcare too.
You know, I'm going to go listen to that episode right after we finish, because he is exactly right. I spend a lot of time thinking about that, and I have thought about each of those things. And as intentionally convoluted and complicated as healthcare has become in this country, you can't point to one person, one system, one anything. There are so many inside deals. There are so many things that we as physicians have absolutely no idea. That is very intentional. As you said, we are not in the room. We are excluded from the room on purpose. They don't want us there. But he's exactly right. It all trickles down. If you look at the maze and the web of healthcare, it all trickles down to the patient-physician interaction. And physicians are absolutely the ones who can save healthcare through unions, through all of the things he's described and mentioned, because you can't. That is one thing that cannot be replaced or outsourced. You need a physician, and that is what generates revenue. That is what sees the patients. But there are many parts to that. I think there would need to be a big media push. I think physicians are not necessarily as beloved in the media and socially as, let's say, nurses or other parts of the healthcare, other members of the healthcare system. There's a lot of assumptions about who physicians are.
Yeah, nurses are definitely more trusted. Like, that comes across on surveys. They're more trusted than physicians. And listen, they're, like, especially for inpatient care, they're with the patients a lot more. So I can certainly understand where that comes from. And they are deserving of that trust. Not that we're not, but I can see why their trust is placed higher than ours. But I do think we're still a very trusted profession. I do. And I think that sacred interaction, the doctor-patient relationship, like, if you're going to be moving the needle on anything, like, you know, I back when COVID came out, I had a bunch of episodes on how to help people understand and get the vaccine. Right. I had a bunch of different people on the show to talk to us, science communicators and a psychiatrist who did motivational interviewing, you know, a couple different people. And a lot of it came down to just this one-to-one interaction, like one patient at a time, because, you know, this is, they trust you. They chose you because they trust you.
You're right. That's right. And you're absolutely right. So many physicians, of course, we feel the pressure that we don't even get the time to build that report. To, you know, we're seeing patient to patient to patient in 15 minutes when we are not a part of your group, and it's not physician owned, and it is corporate private equity owned, and we are expected to see, you know, 4 or 5 patients in an hour. It's more difficult.
Well, that's why you got to listen to my show.
That's the answer.
Teach you how to build rapport quickly.
Clearly.
Build rapport. And there's ways to do it.
That's it. There are, and I will say, working in an ER, as my first job out of residency was working in a pediatric ER for almost 3 years, and I'm going to listen to that episode of yours, but I believe I kind of nailed it too. You're forced to. It's kind of one of those things that you learn along the way. You're walking into a room, you're sitting down, you've got maybe 9 minutes for the family, the mother, the child, the parents to trust you, to tell you everything. In peds, as you know, the kids to trust you. It's a task, but you learn how to do it.
Well,
but I will listen to your episode.
I can give you a couple tips right away. So one
Please,
thing that I learned
let's
from this guy, Nick Boothman, who wrote How to Get, I think the book is like How to Get People to Like You in 90 Seconds or Less, right? One of the tips that I got from him was you got to look at people in the eye long enough to notice their eye color. And when you walk into a room like in the ER, with Peds ER, where you've got family members, that's got to be true for every person. So you need to look at every person, introduce yourself to every person, look at them in the eye long enough to notice their eye color, which is just long enough, but not too long that you turn out being creepy. And then you notice something in the room. Maybe it's something, a shirt that they're wearing or earrings or a keychain, something, and then you ask them about it. And that will help them recognize that you see them as more than the sum of their symptoms, right? You see them as a person and not just something that needs fixing. So you build rapport, and you can quickly build rapport through those two things, and then you dive into it. So, these little things, and they don't take very long, but you put the little bit of work in, and there are systems. Like that's a routine. If you do that every time, you're just going to do it without thinking, and that's where someone like me, who can be socially awkward outside of my exam room. I know it doesn't necessarily come across in a podcast, but whereas becomes more like someone like my wife, who can just do that. And it seems innate, but it's not innate. It's for her, it was just like practice over the course of a lifetime so that it seems, and then we can become more like that through that practice.
That's great. That another great point in that we can learn new skills. The way that we are doesn't mean that's the way we have to stay and the way we have to be forever. It could have been very easy for you to say, well, I'm just not good with people. Well, I'm just not social, so I'm not even going to try. But instead, you did the work. You're reading the books. You're watching how your wife moves and operates, and you're learning new things. And that's a big part of, I think, both of our journeys is picking up new skills along the way. Our educations did not stop in residency and in medical school. And to, grow as humans, grow as doctors, watching the world, being observant, and also incorporating and learning new skills and things so that we can, I think, improve ourselves.
I think it can't stop. I think that's how you live a more fulfilling life, is you just continue trying to be I'm going to steal a line from Ted Lasso, like just trying to be the best version of yourself. I think it was one of the last episodes where he said, well, like, is there an end to it? And it's like, no, it's not an end to it. You just keep on like trying to be a better version of yourself and ask for help when you can and accept it when you can and just keep moving forward. That's I think one of the keys to a fulfilling life is to try and keep moving forward like that. And when you're like, well, what happened when I first started in my practice was I looked at my 2 exam rooms and I was like, so I guess this is where I'm going to be for the next 40 years. Like it's a little depressing. There was nothing to, it was college and then med school and then residency, and there was always the next, and then there was like there was this, because like, fine, I can make partner in my practice, but after you make partner in your practice, it's not like in academia you're like adjunct professor and then assistant professor and then full professor and then you can become head of a department and then you can there's all these different, with my practice, I could run for the board if I wanted to, but you're just like private practice, you're just seeing patients every day. Like there's no like clear next step. So I think it's important for the listeners who are still in practice like me, you've got to figure out some, and I mean, if you're listening to Doctoring Differently, then you know this already. I'm preaching to the choir. You've got to find some other different passion or pursuit that helps you use your creativity, helps you try and push those boundaries of what can I do better and what can I, how can I improve myself and my position. So, it might be outside the exam room, it might be in the exam room, but something that helps you continue to be a better version of yourself.
And that is a great place to take a quick break. And when we're back, more with Dr. Bradley Block. Okay, we're back to the podcast with Dr. Bradley Block. Dr. Block, you are, I will say, a veteran podcaster at this point. So you're used to, I think, publicly voicing your opinions. You know, you had so many episodes around COVID and education for both patients and physicians, medical professionals at large. But I've found that physicians are somewhat reticent to be seen and to be visible and vocal, especially on social media, at least outside of, private forums or private groups. Have you ever had any concerns about recourse from something you've said, from maybe something your employer would see or has seen? I know that you're a partner, so maybe you don't truly have an employer anymore, but have you ever been concerned about something that you have put publicly out into the world?
Definitely. I have probably deleted more tweets than I've put out. I'm always reluctant to put myself out there, because then you never know. And then it turns out like I don't have a very big echo chamber, so there aren't many people reading it anyway. So like the likelihood that it's going to go viral and somehow come back to me, I certainly overestimate the likelihood of that happening, and I maybe should be just hitting send and putting it out into the universe more than I'm reluctant to do so. When I first started podcasting, my practice wanted to make sure that I wasn't doing anything fringe. And so they were like, okay, we're going to listen to the episodes before they come out. And quickly I learned that they weren't listening to the episodes. Maybe they listened to the first one or the second one, but like they had me sending them before they went out, but nobody was listening to them. So I just stopped sending them. They never asked for them. And that was it. That was the oversight. Certainly if it came to their attention that I was producing some stuff that was really like out there, they might have something to say about it. But even as a partner, like it's, you don't want to be besmirching your practice's reputation, right? So, but no, there nothing has come back to bite me. I did have an interview where a reviewer referred to me as being ableist, which I really took to heart. I'm like, I didn't know what specifically I said that was perceived that way, but certainly I don't want someone who is, differently able to perceive me that way or find something that I said offensive. So, that was the most scathing comment that I got. So I really haven't put myself in that position, although I'm certainly getting more aggressive about some of the things that I say, just because I try to push back against pseudoscience. I feel like there's a whole bunch of, people out there that really undermine what we're trying to do in healthcare by pushing pseudoscience. This might offend some of your listeners. I'll give an example. Would be food is medicine. Food is not medicine. Medicine is medicine. Medicine is dosed very specifically with side effects and interactions. And food is food. Food can be therapeutic and medicine can be therapeutic, but food is not medicine. And when you say stuff like that, I feel like it undermines the profession and what we're trying to do in healthcare. And it denigrates the role of medicine. So, like pushing back against stuff like that, I've really started to put more stuff like that out on social media, because I'm getting a little excited about it. I
see it.
It's a passion. It's
I like the passion. No, and I completely agree. I tell, my students, the physician students I work with, it's, if you're going to be on social media, the world needs us. The world needs each of our voices. And we're so, we're scared of the backlash. We don't want, people in our communities, our kids, families, or, to have an alternate opinion and then confront us. We often are very non-confrontational. I've learned physicians outside of our realm of the hospital, right? We're very non-confrontational. We'll use pseudonyms on social media. It'll be, your dog's name and your second kid's middle name, and we don't want to be found. But I tell doctors, listen, the world needs us. We're quiet, but that makes a dearth of actual real information for the public to see
Yes.
and to consume. And you and your community, people know you're a physician, they're going to be watching you and looking to you to say the truth. And when we're quiet, guess what? The pseudoscience people are often the loudest people in the room. So we need to be matching and maybe even surpassing their decibel and their volume, right?
I had an interview early on, and it was about leadership in medicine, and it was why we need to be leaders. And my pushback was, I have 3 little kids. I have a full-time job. I have a podcast. Like, I have so much on my plate, and you want me to put more on my plate? And his answer was, if you don't, someone else will. And that's what happened. That's what's happened. That's what's happened. And so that's why.
That's exactly right.
That's why we need to be in those leadership, in the room where it happens, and putting ourselves out there on social media. Because like you said, that void is very quickly filled with misinformation. And then it goes back and bites us. Like when people then don't trust the healthcare system. And then we have got to go back to building that trust one patient at a time with that interaction that we were talking about before, which takes a very long time, right? It's like Sisyphus pushing the boulder up the hill, right? Like it's going to take forever. So how can we do that more efficiently? And that's through putting ourselves out there on social media. And I'm going to maybe try and practice what I preach and taking more risks. You know, we're risk averse. That's why I delete the tweets, because I'm risk averse, like the rest of us, right?
That's right.
Yeah,
but sometimes
maybe
you
we should be taking more risks.
Yeah, I agree, and I talk about that too. We are so risk averse in as many and avoidant of discomfort in so many realms of our lives, right? We've been uncomfortable through our training, through a lot of our work, so we don't want to continue that discomfort in other places, and we're scared of quote unquote getting in trouble, and we're scared of quote unquote not having permission. But you're right. You know, someone else is going to take the lead. Someone else is going to manage medicine. And the quote I've heard is, "If you're not at the table, you're on the menu," and that's also how I feel about us.
That's a good one.
Yeah, that's how I feel. That's how I feel about healthcare now. So yes, in addition to everything else, we do have to save healthcare. Your economist was right. You're right now. It's exactly right. So you are one of my few guests, as I said, who is still full-time clinical. So how do you balance podcasting, parenthood, being a ENT surgeon? How do you do it all?
I do all of it poorly, I think I'm kidding. So it's, you know, you focus on different things at different times. Like sometimes I'm focusing more on parenting, and sometimes I'm focusing more on my job. Recently, my job has taken a little more of a backseat to parenting and podcasting, and that means I'm getting less revenue, like less income. And I'm doing that in order to build the business of the podcast, and also make sure that I am not, none of this is causing the relationship with my kids and my wife to suffer. Like that's always, because, you know, I think of it like, well, if I was to, you know, get more revenue from the podcast, then I wouldn't have to work as much seeing patients, and then I'd be able to spend more time with my kids. But what ends up happening is you then spend more time building the business of the podcast and then not spending the time with the kids. And so I always have to like kind of find my North Star and be like, what's the priority? Because eventually they're going to be older and they're not going to be interested in hanging out with me. And then I will have plenty of time to see patients and build the podcast business. And so right now, whenever there's like time that I need, you know, they're priority number one. Now, I still need to earn a living, and I still do, you know, this. So there is a balance there, but you can't. I was thinking of a Kanye song, but the lyrics are a little inappropriate to, you know, to say it on a podcast.
Can you give us can you give us the G-rated version?
The G-rated is you're either getting paid or making love, and if you're not doing one, then the other's getting away. You know what? If you're doing one, then the other's getting away.
Okay.
So
okay.
Yeah, and so
all right.
So it's, that's what we're talking about here. If you're doing one, the other one's getting away. Your focus is on one and not on the other. And you just have to be okay with that. Which one is getting your primary focus right now? And then when it's time to switch focus, then you switch focus. But you can't do all of them awesome all the time, and you have to accept that.
Sure. I often think and say that I kind of look at my career like a stereo. Like I can turn the volume up and down on different dials as I want to. I think we've been given, our packaged careers, many of us who go into academics or full-time clinical medicine, you just have a block in front of you and you are full-time clinical and you have no control, and it's, the volume is all the way up regardless of what's going on in your personal life with your family. And so few of us have actual control when we are in those jobs, those full-time academic, full-time clinical careers, without any autonomy. And so my goal for myself and for my listeners and for you and for all doctors is that we all have that ability to, let's say, I'm going to turn down the volume on the clinical side on the job right now and turn up the family side, and maybe then turn up another venture, a podcast, another something I'm interested in, a hobby. And that can happen. We can change those dials and knobs, at any time. It might be different next year, or as you said, when the kids are a little bit older. But we should all have that, I think, ability as physicians to be able to have control over the volume, the bass, the treble of our lives.
Exactly. And the more revenue streams you have, as you help people do, the more control then you can have, because, you might like your clinical job but you know what? You don't like it doing it as many hours, or maybe working for this individual. So the more control you have on other revenue streams, the more independence that gives you, as opposed to having those golden handcuffs that lock you into your current position.
Yeah. One of my guest this season is a contract attorney that we've spoken to. And yes, we've talked about the non-competes and being able to use your medical degree and license that you yourself own and accomplished yourself, and not giving another institution power to determine what you do outside of that one job, so that you can do non-clinical work or consulting or other things, expert witness or medical writing, or these very lucrative virtual even things that doctors can do to supplement income and maybe turn down clinical work. So that's another episode, but I'm glad you have touched on it.
And for those looking at clinical work, make sure that it's in your contract that you can do that stuff, because a lot of times they want you, and they want you all in, and maybe you've got to give them a % of the carve out or something like that, or you're not allowed to do it at all. So that's something that you might have leverage over before you sign. Listen to that episode, because there's plenty out there on contract negotiation that you can listen to. Certainly, we've done episodes on that. So the sooner you start that, the better. You have more leverage, and then you can make sure that you have the ability to do that should you want to, even if you're not thinking of it right now.
Absolutely. That's exactly correct. Okay. You've been podcasting for 6 years, I think, and I have been podcasting for 6 months. So what advice would you give me at my stage so that I can achieve your longevity in this physician podcasting space?
You've got to have your why, and your why can't be listeners or downloads, right? Because that is going to be it's never going to be enough. It's going to be this bottomless pit of, I've gotten, I'm getting 100 episode. Great. Oh, but this person's getting 250. Oh, okay. Well, then I get to 250. 250, great. And then, it's going to, you're going to keep moving the goalpost on yourself. So it can't be about that. It has to be about podcasting for the sake of podcasting. And when you're doing it, you've got to remember why you started it. So for me, it was to help me. My podcast, I'll be totally honest, it's all about me. I'm trying to become the best version of myself. So I interview people that can help me do that. And I figure if I'm trying to learn this stuff, other people might want to learn it too. And so then they tune in and they listen. So mine has always been, but I sometimes get in my head that it's not popular enough. It's not big enough. It's not, I don't have the Instagram followers or the listeners or the downloads or whatever. And then I have to take a step back and be like, yeah, but then why did you start doing this? And that's always, and so then here I am in my basement having a conversation with an interesting person with an amazing, like, inspiring venture that she's doing, that she's helping other physicians. And so, like, it's like, and I tend to do the interviews at the end of the day. So, like, I've seen patients all day. I put the kids to bed, and now I've got to do this other thing. And I'm always like, oh man, why do I do this to myself? And then I get down here and I have a conversation with someone like you, and I'm like, this is why. This is why I do the podcast. This is awesome. Building this network, meeting these interesting people, these brilliant people, and learning from them. So, like, you have to make sure that your why is not, numbers. It's not likes. It's not downloads. It's something else that you're doing it for.
Thank you. That is excellent advice, I think, for all of us who live in an age of social media, period. That is excellent advice. Thank you. Thank you. Thank you. Brad, Dr. Block, I'm going to hit you with my final question that I ask all of my guests, specifically my physician guests. And that is, did this version of your career just happen by itself? Did it fall into your lap, or did you have to take some action in order to make it happen?
So the practice, yes, because my practice was plug and play. Like for everyone in the practice, you can just see your patients and go home.
Okay.
But in other aspects of the practice, not so much. Like, for instance, at one point I was asked by the board to help manage the audiology department. Now, I'm not an otologist, right? My expertise is not ears specifically. There are like subspecialty trained ear, but this was more like, well, helping the audiology department. Like, we have someone in the C-suite who manages the audiology department, but we need a physician counterpart to like help that person from the physician perspective. Because we have all these committees. So they asked me to do that. And for like 6 years or so, I was the head of the audiology committee. And then eventually I stepped down from that. I was on the compliance committee. So, and that was just if I was on the compliance committee and reviewing charts, that would help me get better at coding. So this stuff kind of like fell into my lap. Okay. But now, because of the podcast, I'm very involved in the patient experience at my practice. And this is something that I'm really passionate about, something that I think we can all do better. And, again, it's because of the podcast that I learned so much about optimizing the doctor-patient interaction that when this patient experience opportunity came around, it was like, well, of course. Like, of course it makes sense for me to do that in my practice. And so that was, that was engineered because the podcast took me there and gave me this knowledge. Then there was a platform for me to now disseminate it within my practice. And it's just starting. It's kind of in its infancy. So we're working on that. But that's like, so some of it fell into my lap, but some of it, and like the podcast, is being engineered. And actually something that you and I have spoken about offline is we're creating a network for physician podcasters, for like this B2B, sometimes called like business to business, the physician to physician podcast. We're creating a network so that if you want to start a podcast or you have an established podcast, like we can help you manage it. We can take stuff off of your plate. We can help you optimize it. We can help. So, because, physicians, we don't have a lot of time, like you said. So to like
stuff
get
to do.
Lost in the minutia, like, so we'll take that off your plate. And so I'm working with a couple of other physician entrepreneurs and someone who's not a physician, but she's been in this very, very specific physician podcast space for years. And we're building something so that when physicians want to start a podcast or want to grow their podcast, they can come to us and they can be part of our network. And then, so that was all, because of this podcast, that it was like an itch that I wanted to scratch. Like all of these things are coming from that.
Doesn't it feel good to build something, like, and to have control and to build it from the ground up? I don't know. I'm obsessed with it. It feels great.
Yeah. It's amazing. It's amazing. Like when people are like, "Oh, how's your practice?" I'm like, "Yeah, I'm cleaning out earwax, stopping nosebleeds, and talking to people about postnasal drip." But let me tell you about my podcast network. Like, that's the interesting thing. The thing that you're building is the interesting thing. The patients, yes, listen, it's important, it's critical, it's what we do, it's who we are.
Sure.
But like, you end up seeing the same things over and over, and it stops being as intellectually stimulating. And so what do you do next? Whether your thing is entrepreneurship or research or leadership or policy or politics or, whatever, I think it's important that you just have that something else. You have that something else. Whether it's in medicine or outside of medicine, you need that something else. And I think those that do are the ones that really thrive.
Absolutely. And quickly,
preaching to the choir.
Yes, you sure are. But real quickly, what is the best way to clean out earwax?
Okay, here's the spiel. So I tell everyone the same thing, which is clean your ears like you clean your bottom.
Oh.
Wipe the outside. Don't put anything on the inside. So the ear has a system for making wax and pushing it out in the same way that you have poop and your body pushes it out, right?
Yeah.
Like, and sometimes people get constipated. Sometimes people get ear-stipated and they've got to be disimpacted. But most of the time,
I like it.
I mean, listen, when you say the same things over and over, you develop these like things that to entertain the patients and to entertain yourself. So yes,
I was entertained. You got me.
And yes. And like when people use Q-tips, it feels really good. There's a name for that. It's called an eargasm. So, yeah.
Yeah, you got them all.
I got them all. So yes, the system works. Leave it alone. The body has a system and it works most of the time. So that's the best way to do it. Don't do it. Leave the ears alone.
Wise words. Thank you so much. Dr. Bradley Block, thank you for coming on the podcast. So now our listeners have 2 podcasts to listen to. They will continue to listen to the Doctoring Differently podcast, but head on over to the Physician's Guide to Doctoring with Dr. Bradley Block for more incredible interviews with physicians and physician experts. Thank you for your time.
Thank you so much. It's been a pleasure.